Okay, good afternoon, everyone. My name is Bella, and I will be discussing my master's project, which is exploring modifiable cardiovascular risk factors in people with serious mental illness who are engaged with community care in Australia. So I'm sure everyone here definitely has a working understanding of the term serious mental illness. However, considering the definition can be quite inconsistent in the literature, I thought I would just start us off by explaining the use of the term in my research. So serious mental illness, or SMI, is a group of diagnosable mental, emotional, and behavioral conditions which impair daily functioning. And for the purposes of this project, that's encompassing things like schizophrenia and bipolar disorder, as well as major depression and anxiety. It's a significant public health issue that is estimated to affect approximately 3.3% of Australian adults. So there is a well-established and substantial disparity in health outcomes between people with SMI and the general population. Currently, suffering from a serious mental illness can shorten a person's life expectancy by 14 to 23 years, and this is a mortality gap which has been steadily growing over time, and it is projected to further increase in the future. However, contrary to popular belief, as some of our previous speakers have already discussed today, the vast majority of these deaths are not primarily attributed to unnatural causes such as suicide. Actually, a very large component is due to chronic physical health conditions, such as cardiovascular and respiratory diseases, which are also occurring and being effectively managed long-term in the general population. However, research suggests that for people with SMI, they may account for up to 1/3 of avoidable deaths from these conditions. Now, we all know that regardless of mental health status, obviously cardiovascular disease is a leading cause of death globally. However, for people with serious mental illness, they are 6 times more likely to die from CVD than the general population, and are also more prone to developing CVD risk factors at an earlier age. CVD-related health problems are actually amongst the most common physical comorbidities for people with mental illness. So the ultimate goals of my project were really just to further explore that relationship between CVD and SMI, specifically in terms of cardiovascular risk and clinical management in the primary care setting. And I did this using a research approach which involved a literature review, a descriptive statistical analysis, and qualitative interviews as well. So the first stage of my project was to conduct a literature review unpacking that complex relationship between CVD and SMI. And the major thing that emerged from that review process was the complex interplay of physical, psychological, social, and systemic factors which were contributing to excess CVD morbidity and mortality. These can kind of be thought of under 2 main categories. First is factors that are more centered on the patient's experience, so things like lifestyle behaviors or cardiometabolic side effects from psychotropic medications, among other things. These factors are all contributing to an overall increase in modifiable cardiovascular risk in this population. But then additionally, we also have healthcare system factors and especially disparities in access to healthcare, both in terms of diagnostic processes and then also initiation of treatment. And these failures of the healthcare system to adequately address and manage that increase in modifiable risk is also a strong contributor to the gap in premature mortality. This slide is just talking about some of the aspects of mental illness itself which can contribute to those patient-centered factors and sort of increase a person's cardiovascular risk. And it really underscores this notion, which is increasingly being supported by evidence, that cardiovascular risk and serious mental illness are directly proportional. So increased severity of mental illness correlates to increased likelihood of premature mortality. And that relationship is also bidirectional in the sense that the physical health impacts of cardiovascular disease have an adverse effect on mental health recovery as well. And this really emphasizes how important it is for healthcare to consider both physical and mental health together instead of separately. However, unfortunately, what we see all too often instead is poor clinical management of cardiovascular health when we're looking at people with serious mental illness. And this occurs in 2 major areas that I've centered on in my literature review. The first is during prevention and risk factor intervention. So we see all too often insufficient screening of seriously mentally ill people for CVD and its associated risk factors, and that's both physical risk factors as well as lifestyle-related ones. And actually, one meta-analysis found that less than 50% of patients were receiving screenings for factors like cholesterol levels and glucose levels. This issue extends beyond screening risk factors to just addressing physical health in general, as a 2022 study found that only 1 in 5 healthcare consumers with serious mental illness had experienced a mental health professional inquiring about their physical health. One reason for this is fragmentation, which is basically when all of the different specialists that are involved in the care of a person with serious mental illness are not communicating with one another, and essentially the ball gets dropped regarding their physical health because everyone is assuming that the other team have got it. And another phenomenon referred to as diagnostic overshadowing, which is where complaints from people with serious mental illness about their physical health is dismissed or not taken seriously, or often attributed to being a symptom of mental illness rather than a symptom of an underlying health problem, physical health problem, also contributes to underreporting of physical health concerns. The other big issue surrounding the lack of sufficient long-term treatment methods being delivered for people with serious mental illness is the lack of consideration for lifestyle interventions and an over-reliance on psychotropic medications without any alternatives or strategies to address the associated side effects. And then in addition to that, we have an underprescription or being prescribed in lower quantities medications to target cardiovascular disease and its associated physical health conditions. And of course, as always, underlying these issues is a general issue with discrimination and stigma within the healthcare system when talking about issues that concern people with mental illness. So the major issues which emerged following that initial literature review were the increased modifiable risk and the poor clinical management of those risk factors. And this led me to constructing a new data set, which I used from data that I had obtained from the PharmaBridge randomized control trial, and constructing a new data set using that. So as I mentioned, the data from my project has been obtained from the PharmaBridge RCT. That was conducted over the last few years, in which a group of people with serious mental illness were given a 6-month tailored support service. And that was a tailored support service intervention that was led by community pharmacists and targeted medication adherence and physical comorbidity management, and compared the outcomes of this intervention with a group that had received standard care instead. And so the trial was conducted in community pharmacies across New South Wales, Victoria, and the ACT, in urban, rural, and remote areas of these states. For the purposes of my project, roughly 348 eligible participants completed baseline data collection prior to beginning the support service intervention. And so that my population combined the control group as well as the intervention group because the baseline data was collected prior to any intervention being implemented. Participants consisted of healthcare consumers with serious mental illness from participating pharmacies and were recruited from trained pharmacy staff according to the selection criteria in the table. Baseline data was collected via an online questionnaire, and medication dispensing information was recorded from pharmacy software as well as in discussion with the pharmacist. So from that larger collection of de-identified baseline data, I then constructed a smaller data set by pulling out variables which related to cardiovascular risk. So you can see obviously there's demographic factors, but then also factors related to physical and lifestyle related risk, and also factors related to engagement with healthcare services. And using those, I performed a descriptive statistical analysis. So this first table presents some of the physical risk factors. It shows average results from the population of consumers with serious mental illness and compares them with averages from the general population according to the 2017-18 Australian National Health Survey. And we can see that consistently for all of the factors presented, the population of consumers with serious mental illness had higher averages compared to the general population. And not only that, but also a lot of the averages were notably in a range that would be considered at increased risk for cardiovascular disease, and other physical health conditions. So just to give you an example to explain what I mean by that, if we talk about abdominal girth, typically it is considered that a measurement over 88 centimeters for women or 102 centimeters for men is associated with a substantially increased risk of chronic conditions. And we can see that in this population, the average result was 106.2 for men and women combined. The other thing I looked at was the prevalence of long-term physical health conditions, and we can see once again it's comparing the study population from Farmer Bridge with the general population. And we can see that once again, consumers with serious mental illness had higher percentages of all 4 health conditions presented here. Notably, the difference between the consumers with serious mental illness and the general population is smallest for cardiovascular disease itself. But when we look at these precursor conditions, the gap and the disparity grows significantly. And this is especially notable considering that the average age of the population from the Farmer Bridge study was around 47 years old. So quite young to be developing cardiovascular disease, but definitely the right age to be presenting these precursor long-term health conditions, such as diabetes, high blood pressure, and high cholesterol. And this really emphasizes the importance of early intervention work. In addition, I considered some lifestyle factors. So these are looking at the percentage of each population that met the government's recommendations for exercise and diet. So for physical activity, it's suggested to have 150 minutes per week or more of moderate to vigorous physical activity. And we can see that the general population had a much higher percentage achieving that compared to the Farmer Bridge population. Similarly, with fruit intake, we can see you're supposed to have 2 or more servings of fruit per day. And it's much closer, but still consumers with SMI had a lower percentage in comparison with the general population. But actually, when we look at vegetable intake, notably, consumers with SMI actually had a higher percentage of people in this group in comparison to the general population. However, unfortunately, the vegetable intake, regardless of mental health status, is very, very low, and we want to be improving that regardless of comparison between general and mental illness populations. I'll try and keep going quicker. So won't spend too much time on this, but 24.2% of the study population were consuming alcohol at moderate to high risk, and averaging 11.27 standard drinks per day amongst daily or almost daily drinkers, which is obviously a lot higher than the recommendation of no more than 2 standard drinks per day. And then with smoking, 41.8% smoking at moderate to high risk and median of 15 cigarettes per day amongst daily or almost daily smokers, when of course recommendations would ideally probably be 0 smoking, no cigarettes. Yeah, and so ultimately combining all of the risk factors that we looked at in this descriptive analysis, 92% of the population had 3 or more cardiovascular risk factors, and that's including physical and lifestyle-based, as well as things like age, etc. So looking at this graph, this is the proportion of mental health consumers that were receiving health services in the last 6 months from that Farmer Bridge population. And we can see that 3 of these are related to physical health. So we have a cardiovascular risk assessment, a hemoglobin measurement, and a participating in a health program. And so that can include things like assistance in quitting smoking or an exercise group, things like that. And in comparison, those 3 compared to having a mental health care plan are significantly lower in terms of percentage of that population that had received and engaged with those services. In terms of medication, 24.7% of the population had been prescribed cardiovascular medications with relevant indications. So that just means medications that treat cardiovascular system and also were prescribed for a cardiovascular-related health problem. And then of those who had not been prescribed CVD-related medications, 43.2% had CVD-related long-term physical health conditions. So that's diabetes, hypertension, high cholesterol, etc. And 90.1% of that same group who had not been prescribed CVD-related medications had 3 or more CVD risk factors, which obviously does not imply that they all should have been on medications, because some of those risk factors are just lifestyle-based, but it is still interesting and an area that highlights for future research in more depth. So following from that, I decided to perform some qualitative interviews just to provide some more context. And I won't spend too much time talking on this because I'm still in the analysis stage and I know we have to wrap it up. So I did some interviews, 15 to 30 minutes, peer support workers. It was very interesting. Thank you for your time.
Thanks, Stacey. Got time for one real quick question.
Everyone wants a coffee. Let's go.
Once again, I just have to say this is just fantastic. All of these people are doing their higher degrees, the last three presenters, and wow, and you've sort of epitomised the other two. So let's all thank Bella and also all of the presenters.